Get started. I am Brittany Rogers. Welcome to the webinar on the head, eyes, ears, nose, and throat. Let me first start off by I just introduced myself. So let me tell you a little bit about myself. I'm coming up on my 9th year of being a pediatric nurse practitioner. I have been in primary care for about 9 years now, working at a federally qualified health center for all those 9 years. So it is my bread and butter. I also have my undergrad degree in health promotion and education. So all that to say, I love teaching, I love educating. I hope you all can walk away from this webinar feeling supported and just better prepared for your clinical rotations, for your board exams, and for life after graduation. My goal here is that you would not just be memorizing, but that you would really be learning practical applications to know how to give your patients the best and safest care possible. All right. Let me make sure we're doing this right. Okay. So a quick note, we have recently been certified by the ANCC to offer continuing education contact hours, which is really awesome. If you are joining via Zoom, you'll be getting an automatic email for that contact hour if you stay for the full hour. And if you're joining through other channels, that's totally okay. And I'm so glad you're here, but just in the future, just know that if you want that contact hour, you've got to join through Zoom. So let's quickly go over our learning objectives for today. Like I said before, I really want you to take away something from this lecture that will help you in your clinical practice. So today we'll learn more about some of those common abnormalities that we'll see with the head, eyes, ears, nose, and throat in both the adult and the pediatric patients. We will go through how to assess, diagnose, and manage these conditions. And we'll really try to dive in on the application piece. So as we're talking about these things, I really want to make sure you know about the red flags and when to refer out, because especially as nurse practitioners, we can't know everything. So we need to know when those red flags come up, what to do and where to send them, so we can have a good understanding of what our scope is. And then again, I hope today is fun and interactive and informative. So one of the ways we're going to do that is using Slido. If you've never used Slido before, it's really easy. You can either scan this code on your computer or log into slido.com and do the hashtag HEENT. So I'm going to go ahead and launch the first poll, which is just a quick get to know you poll. So I'll hop over here and start with that one. So this is just a who's in the audience today? Are you a nurse? Are you an NP? Are you a new grad? What's your background? So hopefully everybody's getting logged on, not having any issues. I will put chat support on in case anybody has questions and wants to chat in the Zoom. So hopefully everybody can type questions if you have questions, but is everybody getting onto Slido? Okay. Let's see. Back to my screen. If anyone has any questions thus far, just go ahead and type them in the chat if you're on Zoom. And if you're on Instagram, I can see there should be a way to type questions in there too if you have questions on Instagram. But if we have anybody joining today, you guys can go ahead and log on with Slido. All right. I feel like I might be hopefully doing anything wrong. All right. Okay, we got people typing. It's working. Great. So we've got Patty from Connecticut. Awesome. And I think there's one other person typing. So I'll give y'all a few more minutes just to get it all figured out. Kayla from Tennessee. Awesome. Utah. Amazing. All right. And we've got a couple more people typing. So I'll give y'all a few more minutes. Oh, Patty again. Awesome. A nurse practitioner student. Okay, great. Florida FNP. Amazing. So glad y'all are here. Okay, great. And our next question is, whoops. Where are you joining from? A lot of y'all already answered that. So next question, how confident do you feel in diagnosing and managing these common HEENT questions? And again, zero judgment here. It is totally fine if you're like, I am not sure about any of them yet, but hopefully by the end of this, you'll be feeling a little bit more confident. So it looks like we're somewhere in the middle. So that's great. Everybody's feeling decent about it. That's good. Okay, cool. Moving on to our next question. How many of you have experienced a bacterial infection of the head, eyes, ears, nose, or throat as a patient? And I expect a lot of you have. This is a good question just because we want to remain empathetic to our patients. You know, it's good to remember what it feels like to be in their shoes. We've all been there at some point. I had my third baby not too long ago, and I had a horrible sinus infection. Which is apparently fairly common in pregnancy just because of the increased blood flow and fluid in your body. So it was not fun at all. Okay, cool. So a lot of you guys can agree it is not fun. So we're doing okay with Slido. Let's see. Hopping on to the next one. So we're going to jump into the eyes first. And again, we talked about the importance of red flags. I like to start with these just because, again, we can't know everything about the eye. We're not the specialists, but we can do our best to identify the red flags and get these patients the care that they need as fast as they can. Especially important with the eyes because you really want to preserve the vision and make sure there's not any long-term complications at stake. So examples of red flags with vision changes include sudden loss of vision in one eye, blurry vision, dark spots, a reduction of your visual field. And this would be like when you're looking forward, if you're starting to lose vision on what you can see on the corners of your eyes. On examination, concerning signs would be decreased visual acuity. This is good when you can make sure you get your medical assistant or whoever's working with you to do a Snellen chart. Pupil irregularity, sluggish pupils, or pupillary reaction to light, or definitely a fixed pupil. So going back to Slido, a quick question. I said fixed pupil. What did you guys think of, or did anyone have anything come to mind when you think of a fixed pupil? What could it be indicative of? And don't hold back. You can literally say whatever comes to mind. It's all anonymous here. Nobody knows who's saying which responses. We got some people typing, so I'm gonna give you a few seconds. Brain trauma, absolutely. Brain injury, I increased cranial pressure for sure. Stroke. A couple more people type in. The main thing is definitely serious, impending death, absolutely. Serious conditions that require immediate medical attention. So this is one of the ones that you're like, fixed people is obviously something very, very bad. All right, you guys hit it right on the head. So going into our first question, we're going to review some of those high yield or common board conditions. So this is a patient that comes in with a sudden loss of vision. It's painless, but they describe it more as a curtain over their eyes. So that's another kind of clue word, or some small floaters in their vision. This image is great and it gives you a clue into maybe what's going on. So just don't forget when you're on your boards, really take a good look at those pictures that they give you. So what do you guys think this could be? We'll go to our next slide. What could this be? Any ideas? Retinal detachment. Awesome. Retinal detachment. Good. You guys got it. Okay, great. So yes, retinal detachment. This is an emergency. Obviously, you don't want your retina detached. And it is when the retina separates from the underlying tissue that surround it. And this can happen from trauma or even sometimes from aging. So it's pulling away from that layer of blood vessels and oxygen supply. So obviously, if you're not getting oxygen to the tissue, then we have a big problem. That retina can't work properly, and it can cause total or partial vision loss. Curtain over the eye, that's the most common symptom of the retinal detachment. Again, people may not say those words specifically in practice. You know, they might just be saying that they're slowly losing their vision. So just be aware that on boards, you might see curtain over the eyes, but in real life, listen to try and clue into what the patients are trying to tell you. What else could curtain over the eye indicate? And this is not a poll, but if y'all wanted to write in this poll that we already have active, any other thoughts over what a curtain over the eye could indicate? Any other thoughts? Or if you hear someone kind of describing that condition. I see one person typing. Okay, hemorrhage. Well, really what we're looking at is a blockage of the vessels of the blood supply supplying the retina. So if you have a blockage in one of your main arteries, the carotid artery going up, that would also cause a similar symptom of the curtain over the eye. And sometimes patients with migraines will also have vision changes, and they might report some of the like blind spots or the flashing lights, or they may have other vision symptoms with their if they're having a migraine with an aura. But usually it'll be in both eyes, whereas retinal detachment is more in one eye, and it will usually only last a few minutes to an hour before their headache symptoms starts. Whereas retinal detachment, it will not normally give you a headache, usually affects the one eye, and you're not gonna, the symptoms aren't gonna go away. So any of these, of course, if you're concerned for retinal detachment, emergency. If it's untreated or delayed in treatment, it can cause permanent vision loss. So we definitely don't want that. And they usually have to do surgery to put it back together. So let me go back to your slides. Okay, so next patient. This patient comes in and tells you they've got tingling on the side of their face at first, and then they had a red crusty rash show up. What do you guys think this could be? Oops. Well, I answered on this one. You already saw the answer, but I'll go ahead and go to the next slide. But we've got this red crusty rash tingling. That is going to be herpes zoster or shingles. Yep, and you guys are answering all right, shingles. So shingles is an emergency. Do you guys know why herpes or shingles would be an emergency? Any thoughts on what could be happening here? Let's not go blind. Let's not go blind. I don't think that's a good idea. Vision loss. Yep. So herpes, and we've got one more person typing, Sally, your response. Optic nerve damage, exactly, permanent. So y'all are right on it. So you can see here the trigeminal nerve, cranial nerve 5, has 3 branches, and it starts off in the pons and then it splits. So herpes zoster involvement of the ophthalmic division can cause, obviously, horrible loss to the vision or loss to the optic nerve, sorry, brain part. And if I wanted to show you all this picture because it's helpful to see all the areas that are touched by that V1 branch. So if you're starting to see the similar rash on like the tip of the nose, or even like the side of the nose, or even up here on the forehead, anywhere that's kind of in that V1 area is going to go into that optic nerve that we're worried about. So definitely all of these things, if they're untreated, they can permanently impact the vision. So our goal, we want to diagnose it and refer them out. All right. So I will go ahead and do our next poll. This one's a little bit wordy, so we can read through it together. If you're a fast reader, feel free to go ahead and answer the poll when you're ready. But we have a 60-year-old Asian female presenting to the office with complaints of left eye pain and redness. She states that the pain started suddenly yesterday and has gotten worse. She also has a headache on that side, as well as nausea and vomiting. She thinks her vision is different, but admits to keeping her eyes closed due to the pain, so she's having some photophobia. She wants help since the Tylenol didn't work, and now she's vomiting. Her eye exam revealed a hazy cornea with a dilated fixed pupil, again, those red flags, conjunctival hyperemia, and inflammation of the anterior chamber. So what do you guys think is the answer to this one? What is the most likely diagnosis? Awesome. I think we're all in agreement. Acute angle closure glaucoma. So let's go ahead and go back to this screen. There we go. All right, so answer choice B is correct. Even if you don't know what the answer is, you definitely know that we're going to need to refer out. She had several red flags in there. So when you get questions like this on our Q bank, it'll give you the right answer, and it also gives you the explanation of the wrong answers. So the right answer, you guys all got it, acute angle closure glaucoma. The symptoms plus the physical exam really clue us into this. She's got that sudden pain, it's getting worse, associated headache, nausea, vomiting, photophobia, like she really cannot keep her eyes open. Tried Tylenol, didn't work. Her exam, she's got the hazy cornea, the dilated fixed pupil, conjunctival hyperemia, which just means increased blood flow to the eye. The inflammation of the anterior chamber, that's the fluid-filled space in the front of the eye, between the cornea and the iris. And only an ophthalmologist would see this because we don't have the training, but it's just good to know because if you see those words on the board exam, you can clue into what that means. So we already talked about retinal detachment. That one is usually painless. You've got the floaters, flashing lights, curtain over the eyes. Episcleritis is inflammation of episclera, which is the thin layer of tissue that is between the white of the eye and the conjunctiva. And typically this would be a more milder presentation. So the redness of the white of the eye, you might have a little swelling, tenderness, pain, and sometimes have some blurred vision, but not always. And then conjunctivitis, we are going to talk about that in a few slides. So let's talk a little bit more about glaucoma. This is damage to the optic nerve. So we've got open angle, and this is more gradual. It is not a medical emergency, develops slowly. Symptoms often are not recognized, but they'll have cloudy vision, difficulty seeing when lighting conditions change. They might have some peripheral vision loss. Usually they'll only have central vision loss in really severe cases, so after it's gotten pretty bad. But this is why it's super important in primary care to make sure that our patients are getting routine ophthalmologist visits so they can be monitored for changes. And then acute angle closure or the closed angle glaucoma, this is when the iris blocks the normal drainage of the fluid into the eye. So most people will have no symptoms and then they'll have the acute attack. So these symptoms can be like we saw in our patient, a headache, eye pain, halos around the lights, dilated pupils, vision loss, redness in the eyes, nausea and vomiting. And again, the pressure in the eye is going to be very high. So this is a medical emergency. And again, just really with the symptom exam, make sure you're noticing those keywords that are the hazy cornea, dilated fixed pupils, conjunctiva hyperemia, and then again, if you see that inflammation of the anterior chamber. So they need to go to ophthalmology, they've got to get surgery, and our goal is to catch them early and start treatment to delay progression, and hopefully not get any damage to that optic nerve. All right, and conjunctivitis. This one is super common in primary care, and can actually get a little bit tricky. Sometimes they can start off one way and then turn into something else. So it's good to be super familiar with all of them, and then really good history with this kind of patient. So conjunctiva, again, is that thin layer, the thin membrane that covers the inner surface of the eyelids and the white part of the eyeball or the sclera. Bacterial conjunctivitis is the one that everybody thinks of as pink eye. That's your stereotypical pink eye. And we'll see the crusted eyelids that are shut in the morning. You get that purulent yellow drainage, and oftentimes they will wipe it away and then it will come back pretty quickly. They might get some swollen eyelids. They'll have pain or itching. It may start with just one eye, and that's fairly common, but it will often switch to the other eye just because it's so contagious. And especially with younger people or people that are not washing their hands a lot, they will rub one eye and then rub the other eye, and it will spread. So again, remember when you get that bacterial infection, it's going to have the purulent drainage or pus, and it's dead bacteria and white blood cells all mixed together. So our next poll is going to be, what is the treatment for bacterial conjunctivitis? And I'm not looking for anything super specific. You don't have to name the exact medication or anything, but you'll have some ideas. How do you treat bacterial conjunctivitis? Antibiotic eye drops, bacterial eye ointment, topical, awesome, erythromycin, yes. All right, so I love all of these answers. And I really wanted to ask this question because you can get people that are doing drops versus ointments. It's really helpful to do an ointment, in my opinion, especially with older people who don't have like much dexterity with their fingers or with their hands. And then obviously with little kids, getting drops into eyeballs is really hard. So they're both correct answers. Drops and ointment are great. Ointment is just a little bit easier for specific populations. And again, with patient education on this one, it's super contagious. Really try and keep your hands clean. Wash pillowcases and do your best to really not touch your eyes if you can. If you have contact lens, also, it's important to have them wear glasses until their eyes are healed, and then they need to put in a new pair of contact lenses so that they're not putting the old ones that are already infected in. All right, so let me go back to our picture. Viral conjunctivitis. Sometimes this is a little tricky to differentiate if it's only in one eye, but you'll usually see some other viral symptoms like a cough or runny nose. It's not usually like purulent discharge. It's usually more watery or stringy. But these patients can also sometimes get that crusting. So oftentimes in my practice, I'll have a parent come in that will say, oh, they've got the crusted eyelid this morning, but their eye looks okay. It's not full of goopy drainage, so it is okay to have that like crusted shut feeling in the morning. But then again, with the viral one, if you wipe it away, you're not going to have it fill up with more bacterial or purulent discharge. So it's usually more stringy, watery. It may feel kind of gritty or burning, just some like irritation. And this one, you just treat the symptoms and it should get better as their virus resolves. You can do cold compresses and both bacterial and viral. Um, but they don't necessarily need any drops or anything. And they might ask you, I want a drop for my eye. And they don't need a drop to make it get better. It will get better with time. But do remind them it is still contagious. So again, the same things, hand hygiene, super important, washing pillowcases, all of that. And then allergic conjunctivitis, our last one, they're going to have really watery eyes. It's usually all day or as soon as they come in contact with the allergen. Down here in Georgia, where I am, we normally will have this big bloom of pollen, and that's when I get like this influx of patients into my practice, and they all have just super red, itchy eyes the second they walk out the door. So you'll usually see it in both eyes. And they're usually going to have other signs of allergies, or they may have like the nasal congestion, sneezing. They might be wheezing if they're more asthmatic. What would be the treatment for allergic conjunctivitis? I think we're still staying in the same poll. What would be the treatment for allergic conjunctivitis? You guys know? And anyone can feel free to answer. Let's see. Antihistamine drops. Awesome. Lubricating drops. Awesome. So those are both great answers. We got some more people. Self-limiting. Yeah, so you really can. Your eyes are really good at getting rid of what's irritating them by having some discharge, like the watery discharge. And so that's what's helping clear what's irritating it. So you're right. You can kind of let your eye do its thing if you want to. But yeah, the lubricating drops, you can flush your eye out with just some saline for the eyes, but antihistamine drops, you can get them over the counter. You can also prescribe them. Cold compresses can also help with that itching and that irritation. But again, these patients don't need an antibiotic eye drop, so just make sure you're educating them well. And the allergic conjunctivitis obviously is not contagious. I see it a lot with kids that they'll get sent home from school because they have a redness to their eye and they have to get a note that says they can go back to school because it's just allergic conjunctivitis. So patient education, very important. All right, so two other eyelid concerns I just wanted to talk about. A hordeolum is also called a sty. That's what most people call it. That one is going to be more abrupt onset, usually within the day or overnight. They will get better by themselves, so they improve on their own within a couple of weeks, usually 1 to 2 weeks. They do not need any antibiotics. There's no literature that says they need an antibiotic. You really just do warm compresses, and it's going to be like 4 times a day. So you really want to make sure that they're doing 10 to 15 minutes, 4 times a day to help open up that gland and help it resolve. And a I never say the word right. Chalazion. It is an inflamed sweat gland or the meibomian gland. This is a more gradual onset. The upper eyelids are more common, but again, you also need to do the warm compresses. And if it's not getting any better, they can go see ophthalmology because they sometimes need to get them removed and get them, surgical removal or injected with a corticosteroid. So a quick break. This is just an overview of some of the things that we have going on at Archer. If you have any specific questions, we've got our email down at the bottom right-hand corner, and we are always here to chat with you and support you guys. You can follow us on Archer or on social media at Archer FNP for updates. Join our community on Facebook for peer support. We have some amazing prep tools. So our question bank is awesome. There is a free demo if you wanted to hop on and do some similar questions, similar to the one we did for glaucoma. The on-demand section is an amazing resource with a lot of shorter, like straight to the point videos that cover a lot of the most important content you need to know. And then our most comprehensive exam prep tool is the SurePass Pro, which this one basically just includes all of that. So it's got your Q bank, your on-demand content, your live review, it's got mentoring. The main thing with this one is there is a pass guarantee. So you can approach your studies knowing that we've got your back and we're going to help make sure that you get that pass. So we are committed to providing affordable and effective resources so that you can conquer your AANP or ANCC exam. So again, check in with us, connect with us, join our community, and we are here to help. So our next patient, diving into the ears, we have a patient who has a fever. They've got ear pain. You look at the tympanic membrane and it is red and bulging with purulent fluid. We have a beautiful little picture right there showing you what it looks like through your otoscope, and then again the anatomy of the ear. So what do you guys think this one is? Acute otitis media. Awesome. Otitis media, otitis media. Y'all are doing great. You guys got this. So it is acute otitis media. Who can tell me what the first line treatment is for acute otitis media? You can add it into this one too, unless maybe first line treatment. Okay, what is the treatment for acute otitis media or an ear infection? What a lot of people say, but it really is the infection of the inner ear or middle ear. Awesome, you guys are doing great. So we really, depends on watch and wait, but if not antibiotics, exactly. So you guys are awesome. In adults, it's Augmentin is the first line treatment. In kids, you can do high dose amoxicillin. If it is an allergy, looking at a cephalosporin or doxycycline. Let me go back to our poll. Does anybody know the difference between otitis media and otitis media with effusion? I think someone was kind of hinting at that, but they're fairly similar, a little bit different. Fluid, exactly. So in acute otitis media, you've got the bulging with purulent fluid, and it's going to be really red and irritated. And then with otitis media with effusion, like you guys are saying, effusion, you've got fluid, but you really don't have the bulging and you're not having a lot of that redness. So it's more just like fluid behind the tympanic membrane. Again, yeah, you guys are hitting it right on the head. Effusion won't be as red. It can persist for weeks afterward. So this is super important just because the treatment's different. We're going to treat in acute otitis media with antibiotics. And with otitis media with effusion, we're treating those symptoms usually in the sinus cavity. So doing a nasal steroid to try and help get that fluid to come out on its own. And if symptoms persist with otitis media with effusion or they're reoccurrent for more than usually about 12 weeks or a few months, then you can refer them to the ENT. Or obviously if the symptom is bothering them and it's not improving, then definitely get them in with the specialist. All right. And let's see. All right, so we've got our next question. This person comes in with pain when you move that pinna. So again, that's kind of like your outer ear. And usually I will notice this when you go to do the otoscopic exam and you're trying to get their ear position correct. And they are like, "Ooh, ow, don't touch my ear." Um, so they have pain with movement, their tympanic membrane. If you can see it, it looks normal. Do you guys know what this one is? All right, never mind. We'll leave it on this one. I will go ahead and tell you guys because I think I messed up this poll. So this one is otitis externa. You guys probably could have guessed that. But this is what also people call swimmer's ear. So it is treated with ear drops. If you cannot see the tympanic membrane, sometimes that canal is so swollen or it has just so much fluid in it, like debris. If you can remove a little bit of it and it's not too painful for them, then you can see the tympanic membrane, then it's fine to go ahead and do the eardrops. But what would you guys do? Can you prescribe eardrops for a ruptured tympanic membrane? What would you guys do there? Awesome. All right, you guys said no. So yeah, if it's severe or it's ruptured, we're gonna want to refer to the ENT and we'll usually get a culture. So if you cannot visualize that tympanic membrane due to either inflammation or a lot of debris, I would go ahead and refer them. And if it's not improving after 7 days with your drops that you did choose, if you could see the TM and it's not improving, you can definitely also go ahead and refer there also. All right. So we have another practice question. So this one is a 5-year-old male, comes to the clinic with right ear pain for 2 days. On physical exam, his tympanic membrane is erythematous but intact. The nurse practitioner suspects acute otitis media. The patient's mother denies a history of recurrent ear infections. The NP wants to prescribe amoxicillin. So the question here is, how many days? So how long would we treat this child with amoxicillin? Now I'll go to the next one. What do you guys think? Awesome. 5 to 7 days. Any other thoughts? All right. Well, you guys are doing great. The answer is 5 to 7 days. And that is for patients with severe or recurrent acute otitis media, or if they've got perforation, or if they're younger, 2 years old, then we are going to treat for 10 days. If they are over 2, the symptoms are mild to moderate. They don't have recurrent ear infections. A shorter course is okay. The 5 to 7 days can be sufficient. I always, I'll get my patients back in after, or I'll even let them know if they're not improving after a couple days to bring them back in and I can take a look at it. But you can get them in for a recheck to make sure that they're improving. But 5 to 7 days is okay if it's not a severe or recurrent case. All right, so our next question, this is another super common one in primary care. Very important to know what's going on. So this patient comes in with symptoms of facial pain. Sometimes they might get referred tooth pain. They've had recent viral symptoms like nasal congestion, a sore throat. They originally had drainage, but now they don't have any drainage anymore. What could this be? What are your thoughts? Sinusitis. Awesome. Great. Y'all are doing great. So the answer here is sinusitis. Oh, there we go. Okay, so y'all are right. It is sinusitis. The treatment is, what do we know? Does anybody know what the treatment is for sinusitis? And we're going to go ahead and say this is bacterial sinusitis. Symptomatic. Okay, so you're right. You're not wrong. If it's If it's a viral sinusitis, symptomatic treatment is totally fine. If it's bacterial, though, you got it. It is augmentin. And augmentin is that better choice over just plain amoxicillin, just because that beta-lactam ring really helps the medication penetrate the bony sinuses better. So let's talk a little bit more about what is the difference between viral and bacterial sinusitis, because again, this is one that you're going to see a ton in primary care, and you have to do a lot of patient education um, because people don't know the difference, and they come in and they're feeling bad and they want help. So you've got to be able to explain to them the difference very clearly. So what do you guys know? What are some of the differences between viral and bacterial sinusitis? Any thoughts? Anyone want to answer? Got some people typing. Longer signs and symptoms, purulent rhinorrhea, facial pain, fever. Awesome. Okay, great. Oops, I gotta go back to my web. You guys got it. So here's our nice little graphic. A lot of times sinuses or sinus infections will start out as viral upper respiratory symptoms. They increase that mucus production in the frontal and the maxillary sinuses. They'll have some nasal drainage and postnasal drip. That's all more viral sinusitis. So just inflammation of the sinuses when you have an upper respiratory infection. Once they get really swollen and inflamed, they start to get some blockage due to that inflammation, and that mucus gets stagnant. And that's more when you're going to have the secondary bacterial infection come in. So they usually don't have much drainage anymore. If they do, like you said, it may be more purulent looking drainage. The red flags here would be a lot of pressure or tenderness on one or both sides of the face. So this is where it is okay to touch your patient's face and really push and see, is it hurting when I push here? Is it hurting when I push here? And if they're kind of, feeling that inflammation, they're going to let you know. If they've been sick for longer than 10 days, or if they thought they were getting better and then they seem to get worse again. So they'll usually describe, I had a cold, I thought I was starting to get better, it had been a couple days, and then I really feel like I turned the corner and got worse again. So, and they might start to have that low grade fever as well. They may have a fever in the beginning and then they seem to be getting better, and then they start to run that low grade fever and get those headaches again. So those are all signs that it has turned bacterial. All right, so moving on down to the throat. You guys are doing great. We have a patient who comes in with a sore throat. It started a few days ago. It hurts to swallow. They've got palatine petechiae, small red dots on the roof of the mouth. They've got post oropharyngeal erythema and edema. So it could be frank. In that case, it would just mean it's very red and very pronounced. And you also feel anterior cervical chain adenopathy. So what do you guys think this one could be? Looks like strep, pharyngitis, strep throat. Awesome. All right, you guys are doing great. So it is strep throat. So what causes it? Streptococcus coccus pyogenes. I shouldn't be trying to pronounce these things. We treat with antibiotics. So the hallmark sign of strep, obviously, besides a sore throat, they might also be getting a stomach ache. They might see a headache. They might get those palatine petechiae. So those little blood vessels on the back of the palate can get red and broken, and they look like little dots. Um, it's more common to see anterior cervical chain adenopathy with cases of strep. We will treat it with antibiotics. We usually give a penicillin. If there is an allergy, you can do something like azithromycin. And if it does not get treated, it can cause serious issues. It can cause rheumatic fever, which can impact the heart, cause some kidney inflammation. So it's super important that we test. If you do a rapid strep test and it comes back negative, but you're still thinking this looks a lot like strep, really make sure you culture. I always do a rapid and a culture at the same time. I treat a lot of kids, so I want to make sure that I'm just not having to do multiple swabs in there. But if you can, if you're still not sure, go ahead and do a culture that will, take a day or two, but we'll make sure that we get them treated if they need the antibiotics. So our next one, if the strep test comes back negative, but the patient has a sore throat, and in this case, instead of having that anterior cervical adenopathy, they have more posterior cervical lymphadenopathy. Um, their sore throat's super severe. They're really fatigued. They might have a fever at night, loss of appetite. They might be starting to have weight loss if they've had it going on for a while. Their physical exam looks a little pretty similar to strep. They might have tonsils with exudates. What do you guys think this one could be? Mono, awesome. What's another name for mono? Or what causes mono? Any thoughts? Epstein-Barr virus, awesome. All right, you guys, great. So we've got mononucleosis, caused by Epstein-Barr virus. And in this case, do we give antibiotics? We do not. We want to avoid antibiotics because if you do give antibiotics, you actually can cause them to have a rash. So with mono, we're just treating them symptomatically. This patient is going to be super important to do patient education for. So what do we want to make sure we want to educate our patients on with mono? And has anybody ever had mono? I actually had mono when I was younger and it was horrible. I feel like it lasted for forever. No sports for 6 weeks. Yep. Again, we got the sports contact. Don't do that. No kissing. Yep, that's right. It's the kissing disease, symptomatic management. No kissing because it is more common in adolescents and older people. So, they're more likely to kiss each other. So you got to make sure that, yeah, no kissing so they don't spread it. No sharing food, no drinks. Spreads through the saliva. We do want to make sure we are educating them about the contact sports. So your spleen is in your left upper quadrant. And you shouldn't be able to feel a spleen normally in most patients. But if you have them lay down and they do the deep breath and you feel that enlarged spleen, whether or not you feel it, still with mono, you want to make sure you're educating them, but especially if you're feeling an enlarged spleen. We don't want to have any splenic rupture. So no contact sports. They're probably not going to want to play contact sports, but if they're starting to feel better, just make sure they know they still can't go back to playing sports for at least 6 weeks. All right, so our next one. This is a patient, we are looking at their throat and we see that their uvula is displaced to one side and they've got that classic hot potato voice. That means, if they cannot close their mouth all the way to articulate, they're obviously having some serious inflammation in their throat. So this would be a peritonsillar abscess. This is an emergency. We send them over to the emergency department. It will need to be evaluated and drained. So again, if you see that uvula displaced and they've got the hot potato voice, go ahead and refer them to the emergency department. And our next question, we have a 5-year-old brought to the clinic by his father who's experiencing difficulty breathing and worsening symptoms over the last 12 hours. The father reports that he had a mild cold last week, but now has a high fever, a hoarse voice, and is leaning forward in a tripod position. Red flags. He's breathing with an open mouth. He's got super severe inflammation. This child is visibly anxious probably because they can't breathe well, drooling, they have difficulty speaking. On physical exam, you note tachypnea, so they're breathing faster. They've got tenderness in the anterior neck and large cervical lymph nodes. Which of these is the most likely diagnosis? For some reason, my answer slide is not working on this one. So the answer here is epiglottitis. So it's inflammation of the epiglottis, and that is that little leaf-shaped flag in the back of the throat that when you swallow, it prevents food from entering your lungs. So it's open during breathing, it closes during swallowing. If you've got inflammation back there, you're restricting your airway and causing swallowing issues. So that's why you've got, the tachypnea, the anxiety, they're drooling, they've got airway issues. It's caused by an infection. It's caused usually by Haemophilus influenza B. We do give vaccines for it, so that's why we're not seeing it as often. But it is a medical emergency, and they will need to go to the emergency department also. Some of the other answers, we already talked about the peritonsillar abscess. We talked about strep. Croup is generally less severe. They're usually going to have a barking cough with it. It's usually more of a gradual onset, and they're not going to have those issues with swallowing and drooling. They might feel like they also can't breathe, but they may not have that, the swallowing, drooling issue. All right, so one more just quick review of what we've got. I just want to make sure everybody, is aware of what we offer and how we can support you guys. And I wanted to do a quick check-in. Oh, and I actually had a poll for you. I'm sorry. I didn't give you guys the chance to answer. But how confident are y'all feeling about some more of these H, E, and T questions? Are we feeling better? Feeling the same? Hopefully feeling a little bit improved. Looks like we're doing better. Awesome. We got lots of happy faces. This is great. Okay, cool. So again, with our resources we've got, please check out the question bank. It's super helpful. We've got so many different topics in there. It really helps you feel a lot more confident. The on-demand videos, again, are amazing. They're like little bite-sized videos of just really getting to the point of the content you need to know. And then that SurePass Pro, if you want to go for all of them, really will help get you that pass. So you want to look into all of those. You can scan. It's got a wonderful little scan feature to make it easy for you. But also just join our community. We really like having more nurses, more NPs, everybody, just connecting with each other, asking questions, seeing how we're all doing. It's a community and team effort here. All right, so our last case study, this one is going to be pretty classic. We're getting to the end of our time here. So we'll just kind of read through Miss Jane's situation. She is a 45-year-old female. She's got a history of seasonal allergies. She's pretty sedentary. She's an office manager. She's got a poor diet. She exercises occasionally. She comes to the clinic today with nasal congestion, sinus pressure, mostly in her forehead. It's only been there about 3 to 4 days, but it does feel like it's getting worse. She's got the drainage in the back of her throat, occasionally causing a cough, usually when she's laying down and sleeping at night. She's got the history of the seasonal allergies, and she says, I always get a sinus infection at this time of the year. She took some Mucinex. She's taken Sudafed, didn't really feel like it helped. Her vital signs are stable though. She is on physical exam. Her nose is erythematous and edematous. It's got some thin, watery discharge. There's not any tenderness when you palpate over those maxillary and frontal sinuses. She's got mild post-nasal drip, but she doesn't really have the frank erythema, pus, no exudates. Her tonsils are pretty normal. Everything else looks good. What are our initial thoughts on Miss Jane? Any ideas of what we would diagnose her with after our history and our physical exam? Supportive care, yes. Good answer. Any other thoughts on what you would do with Jane? Or what she's got going on? Symptomatic care. So this one is a super common one that we see obviously a lot in primary care, like we talked about. Clean out those sinuses, yes. This is a patient who is going to come in and probably want more medication from you and maybe want an antibiotic, but this is viral rhinitis. It happens so much. This patient really is miserable, so I'm not blaming her. It's not fun to be sick, and she's wanting something to help her feel better. But again, this is where we're really gonna want to push the patient education. So we don't need antibiotics with this. The nasal saline rinse is awesome. Got to get all that mucus out. You don't want to be too aggressive, but some gentle flushing is okay. Follow up with Flonase. You can do it twice a day. And you've got to be consistent with this because as a nasal steroid, it will take some time to kick in. Honey is awesome. It's a great mucolytic. It helps hydration again with the honey. So if you're doing like a warm tea with honey in it, that can help. Hydration is really the very best thing. So really telling them to drink a lot of water. And a lot of people, they're not necessarily like feeling super thirsty. So you're just gonna remind them, go ahead and just keep drinking even if you don't feel super thirsty. The hydration will help thin out the mucus. And then of course rest, making sure that they're not still trying to do too many things at this time and they're just letting their body heal. Warm showers can help. I'm not a huge fan of decongestants just because there's a lot of side effects. And so if they've got blood pressure issues or cardiac issues, um, make sure that they are really just trying to stick with symptomatic care. What if I told you though that she comes back after 10 days and she says she initially got better, but then she started to feel worse and now she can't blow her nose and she feels that pressure in her face. She's got pain, she's got a headache. What would you guys think it has changed to? And what are we going to prescribe? I'll give y'all a few minutes. I think you got this one. Antibiotics, awesome. So it is now acute bacterial rhinosinusitis, and y'all are right on it. We would prescribe antibiotics. Augmentin is that first line. Yep, so y'all are right. You got it. We're going to do Augmentin unless they have an allergy. And here's our slide. If they have an allergy, we're going to do doxycycline. But Augmentin, you're going to do that higher dose for 10 days. And our patient education here, really again, empathizing with them, understanding that they feel bad, and now that it has turned bacterial, making sure that they are taking the medication as prescribed. A lot of people will take it for a couple days and then they are like, oh, I'm feeling better. I don't need to finish it. So make sure that they finish the whole, put the full 10 days. Come back to the office if it's not improving. With Augmentin, there is a higher occurrence of yeast infection, so it's okay to take with an antibiotic or with a probiotic. I usually recommend taking their dose in the morning and then doing a probiotic around midday and then taking their next dose of Augmentin at night. With doxycycline, make sure that they drink a full glass of water. So if they take a medicine and then they lay down and it's still kind of in that esophageal area, it can cause a like painful esophagitis. So sit upright for 30 to 60 minutes after you take, especially doxycycline. And it's okay, especially with these stronger medicines, to take it with food just because it's not going to feel good on the belly. So again, if you start them on an antibiotic, they are not feeling better after the first 2 to 3 days, or if they really feel like they're getting worse, if they start to have any kind of like swelling or like looking like they're getting periorbital cellulitis, we need to get them back in, or any kind of abscess formation that's not improving. So counsel them on what the return to office symptoms would be. And then again, they can continue to do the symptomatic treatment in addition to the Augmentin. So the hydration, rest, saline, they can do the Flonase, you can do an oral antihistamine, again, if you also have the seasonal allergies going on. All right, so we've made it to the end of our time. Y'all did amazing. Thank you so much for your participation. If you have other questions, I will put up this Slido poll and y'all can let me know if you enjoyed doing Slido. I think it's kind of fun. It's an easy way for y'all to jump in and participate, but we'll love to hear from you if you enjoyed using Slido today. And I will also put up a quick poll at the end if you have any suggestions for future webinars. So I'm glad you guys liked using Slido. Good. Let's see. Awesome. 8s, 9s, and 10s. Great. What content would y'all like to see in our future webinars? If y'all have any other thoughts for things that you want some extra help with, let us know. And you can add that in there. And I wish you guys all the best of luck. I hope this was pharmacy. Okay, I will take note of all of these and pass them on. But yeah, thank y'all for joining in, for participating. I hope it was helpful for you guys. If we can do anything else, again, email us. All right, we got all of these great answers. I will add our slide at the end with our information we've got. It looks like a couple people are typing, so I just want to make it cardiac, the big three. Okay, cool. Awesome. we will work on getting all of this in webinars for the future. Definitely. I see one more person typing, so I just want to make sure everybody has their chance to participate. Okay, and our last little slide. So if you need us, email us down at the right hand of the screen, nursepractitioner@archerreview.com. Also check in on our amazing resources and also join all of our social media and connect with us. So thank you guys again. Email us with questions, and I hope y'all had a great time. I am going to end our chat if I can figure it out. There we go. Let's see. I think my screen. Oh, thank you, Tracy. There's my end button. All right. Thanks again, guys. Have a great afternoon.